This is a 55 years old male, known case of diabetes, uncontrolled diabetes, now presented to the emergency department with severe chest pain, typical chest pain. And on ECG, there was a ST elevation in V1 to V6, 1 AVL. And since 2 hours, he has a chest pain. And on echo, there was a mild RWMA in the LAT territory with a moderate LV systolic dysfunction. And the patient was taken for the angiogram after all clearances, and this is the angiogram with the right radial root. This is a tiger catheter. You can see there is a thrombus right from the proximal LAD. LAD is still flowing well, but there's a thrombus seating in the right from the proximal LAD. This is a yellow caudal view, and you can clearly make out the thrombus, the haziness in the proximal LAD. And this is a AP cranial view, and you can see the same thing, the thrombus in the proximal LAD up to the diagonal. You can see the thrombus. The LCX is overlapping here. Let's see in the RO cranial view. And this was the RO cranial view, and you can clearly make out the thrombus in this proximal LAD as the patient presented early. You can see clearly the thrombus and haziness. So in this case, this LAD is almost going to close. The patient was lucky. He has presented within the 2 hours of a chest pain. You can see how LAD got thinned out in the proximal segment. So after obtaining all clearances, we proceeded for the angioplasty for this patient. And I forgot to show you the RCA. And very surprisingly, this is the RCA, and there's a CTO in the RCA. I'll show you the collaterals. There are subtle collaterals getting from the LAD to this RCA, and this is a CTO probably 3 months. And you can clearly make out the collaterals to the RCA from the LAD, subtle collaterals you can see. I'll show you the steel frame. So with this arrow, I'm showing the collaterals from the septal to the RCA. So basically RCA is getting collaterals from the LAD, and there's the thrombus, subtotal thrombus in the LAD. So just imagine the patient is getting collaterals from the LAD, and there's a thrombus seating in the proximal ostial LAD. So if the patient had presented late, probably he would have died. So with the right radial root, with this XB 3.5, we started the procedure with the simple BMW PTCA wire, where so I wanted to cover right from the ostium because the thrombus was there. So this is the placement of the stent in the iliacoidal view. Always place the stent in the iliacoidal view to see the ostium of the LAD. You can see 1 or 2 slot I kept into the LM. So I wanted to do the nail the ostium, and then I confirmed the distal edge of the stent, and the stent was deployed at around 14 atmospheric pressure, as it was a 2.75 stent. Deployed at around 14 atmospheric pressure, RBP was 16, it was nominal in the iliacoidal view only. And now this is the picture after the angioplasty. You can see how big type 3 LAD he has. So this is the cranial view after the angioplasty, and you can see good expansion of the stent. And this was the primary angioplasty to this 55 years old male. And we have planned a stage PTCA to the CTO RCA. The patient's vital was stable at this point. Shifted to ICU. Thank you.